So when you try to picture, like, the most dangerous environments a human being can possibly navigate,
Yeah.
your mind naturally goes to extremes, right?
Absolutely.
You might think of, I don't know, the crushing pressure deep underwater,
Right.
or maybe the thin air of a high-altitude peak.
Right, or like a freezing, desolate tundra somewhere.
Exactly. We picture these scenarios where survival is this active, conscious, minute-by-minute struggle.
Yeah, you're fighting the elements.
But what you probably don't picture is the quiet, dark space of your own bedroom on, like, a typical Tuesday night.
No, definitely not.
Because we have this deep-seated, built-in assumption that when we lay down, pull up the covers, and close our eyes, we're stepping into an absolute safe harbor. I mean, sleep is supposed to be the ultimate biological refuge.
It really is. It's universally associated with cellular healing and restoration.
Right. But for a staggering number of people, that refuge is actually a battleground. Like, while you are lying there completely unconscious and seemingly at peace, your physiological systems might be fighting a violent, desperate war just to maintain baseline survival.
It's a profound contradiction when you map it out biologically.
Yeah.
Because, as you said, we associate that dark, quiet bedroom with memory consolidation, physical restoration. But for a massive segment of the global population, that exact environment is where they endure repeated severe physical trauma.
Which is just wild to think about.
It is. The sanctuary of sleep is completely hijacked by a mechanical failure in the body.
And mapping out that covert, invisible threat is our mission for this deep dive today.
Oh, absolutely.
Because we are unpacking some incredible insights from health expert Gary Brecka's Ultimate Human podcast. We're specifically focusing on a condition that hides in plain sight, which is sleep apnea.
Yeah, and the way Brecka breaks this down, it really changes the entire paradigm.
It does. We are looking at the foundational causes, the really severe hidden risks, and the medical frontier of how we are treating it. Because what we're talking about fundamentally changes what a bad night's sleep actually means.
Completely.
And to give you a sense of the scale here, we are dealing with an issue that affects an estimated 1 billion individuals globally.
Yeah, let that sink in. 1 billion.
1 billion. That is roughly 1 out of every 8 human beings on the planet dealing with a condition that actively cuts off their oxygen supply while they're completely vulnerable.
And, you know, the historical context of how we viewed those 1 billion people is fascinating and, frankly, a bit tragic.
Yeah, how so?
Well, for decades, society, and to a large extent, even the clinical medical community, just dismissed this condition as a nuisance.
Right, it was just snoring.
Exactly. It was categorized as a snoring problem. It was like the punchline to a joke about keeping your spouse awake.
Oh, totally. The dad snoring on the couch joke?
Right. But the modern clinical consensus, which is heavily emphasized in the source material today, has completely discarded that view.
Thank goodness.
This is not a volume issue in the bedroom. It is a critical, systemic public health crisis.
Okay, let's unpack this. Because to understand how a loud annoyance gets reclassified as a physiological trauma, we have to start with the actual engineering of the human airway.
The literal mechanics of it, yeah.
Right. Because before it becomes a systemic health crisis, it really just starts as a simple structural collapse. I mean, the airway is essentially a tube made of soft tissue, right?
Yep. Muscles, ligaments, the soft palate, the base of the tongue.
And during sleep, that soft tissue completely fails. It just falls backward and effectively glues itself shut, completely blocking the windpipe.
Yeah. The pharyngeal anatomy is uniquely vulnerable in humans.
How so? Like more than other animals?
Actually, yes. Unlike many other mammals, our ability to speak requires a very flexible, pliable vocal tract.
Oh, interesting.
But that evolutionary advantage comes with a significant structural trade-off.
Because it's too soft.
Exactly. Because the walls of the upper airway are soft and lack rigid cartilage, their patency, basically their ability to stay open, relies entirely on muscle tone.
Okay, that makes sense.
And when you enter sleep, particularly the deeper stages of sleep, your body naturally decreases muscle tone.
Which you want it to do. You want to be relaxed.
Right, you don't want to be acting out your dreams. But for someone with obstructive sleep apnea, that normal relaxation just goes a step too far.
Oh, I see.
The muscles of the soft palate and the genioglossus muscle, which controls the tongue, they just lose too much tension.
I picture it like a really cheap paper straw.
Oh, that's a great analogy.
Like if you're drinking a super thick milkshake and you pull on that straw, you create a vacuum, right?
Yep, negative pressure.
And the walls of the straw just can't handle the negative pressure and they cave in on themselves. Your lungs are acting like the suction, trying to pull air in, expanding your chest. But the structural integrity of the throat just fails. The airway pinches completely shut at the exact millisecond the flow of oxygen is needed most.
And the physics of that analogy are highly accurate. In respiratory mechanics, we look at what's called the critical closing pressure.
Okay, what's that?
Well, when the lungs expand against a blocked upper airway, they generate massive negative intrathoracic pressure.
So a huge vacuum inside the chest.
Exactly. And the harder the diaphragm pulls down to try and get air, the stronger that vacuum becomes.
Oh, wow. So you're making it worse by trying to breathe.
Yes. The more forcefully the tissues of the throat are sucked together, the body is essentially fighting its own anatomy.
That is terrifying.
It really is.
Yeah.
And this mechanical failure is the trigger point for what Gary Brecka outlines as the hypoxic model.
Right, the hypoxic model. Let's get into that because hypoxia simply means a state where oxygen is not available in sufficient amounts at the tissue level.
Exactly. It's an oxygen deficit.
So when that paper straw collapses, we aren't just talking about a pause in breathing. We are talking about actively starving the cellular machinery of its primary fuel source.
Yeah, and every single cell in your body relies on oxidative phosphorylation to generate ATP, which is cellular energy.
So without oxygen, everything grinds to a halt.
Basically, yes. When the airway collapses and blood oxygen saturation drops, you are shifting the body from a state of repair to a state of absolute physiological panic.
Even though you look perfectly calm on the outside.
Right. During sleep, your brain is trying to clear out metabolic waste, your immune system is repairing tissue, your endocrine system is balancing hormones.
All the maintenance work.
All of it.
Yeah.
And none of those complex biological processes can function efficiently in an oxygen-deprived environment.
So what does the body do?
Well, the brain registers the plummeting oxygen levels and the rising carbon dioxide levels, and it initiates an emergency override.
The emergency override being what the clinical literature calls an arousal period.
Yeah.
The brain basically realizes the body is suffocating, hits the panic button, and blasts the nervous system with adrenaline.
Right, to force the airway muscles to tense back up and take a breath.
And the data shows this can happen hundreds of times in a single night.
Hundreds of times. It's staggering.
But wait, here is the logical disconnect for anyone trying to understand this, and I had this question myself.
Sure.
If my brain is chemically shocking my system with adrenaline hundreds of times a night to save me from suffocating, how is it possible to have zero conscious memory of fighting for my life the next morning?
That's a great question, and it really highlights the layered complexity of human sleep architecture.
Okay, break that down for me.
An arousal, in this clinical context, does not mean achieving full conscious wakefulness.
So you're not sitting up in bed gasping?
Not usually, no.
Yeah.
We measure sleep in stages, right? Light sleep, deep slow-wave sleep, and REM, or rapid eye movement sleep.
Right, the norm cycles.
When the brain detects the hypoxic emergency, it doesn't need you to open your eyes, sit up, and process your surroundings.
It just needs you to breathe.
Exactly. It only needs to jolt the central nervous system just enough to shift you out of deep sleep into a lighter stage.
Ah, I get it.
Because shifting to that lighter stage restores basic muscle tone to the pharynx, so the airway snaps open.
So you were basically yo-yoing all night.
Yes, that's a perfect way to describe it.
You drift down into the deep restorative sleep where the real cellular work happens, the throat muscles relax too much, the airway collapses, oxygen drops, the brain panics, yanks you back up to light sleep, you take a breath, and the cycle starts all over again.
Over and over.
You never break the surface of consciousness, but your neurological sleep architecture is just completely shredded.
Shredded is the exact word. The EEG, the electroencephalogram of a severe sleep apnea patient, is just chaotic.
It's just a mess of spikes.
Yeah, there is no sustained slow wave sleep. There is highly fragmented REM sleep.
Wow.
Because the biological requirement for sleep isn't just about the passage of time, it's about the continuity of those cycles.
Right, you can't just piece together 10 minutes here and there.
Exactly.
Yeah.
You could spend 10 hours in bed, but if you're experiencing 50 microarousals an hour, you have effectively received 0 restorative sleep.
Which perfectly explains the morning aftermath.
Oh, yes.
Because the analysis uses this highly descriptive phrase, waking up in a suffocated state.
It was brutal.
It's not just feeling a little tired. Sufferers are waking up with intense morning headaches and this profound grogginess where it takes them like 45 minutes to an hour just to clear the fog and get their motor going.
And if we look at the biology we just discussed, those headaches make perfect sense.
Because of the oxygen dropping.
Actually, it's the carbon dioxide. If you aren't breathing properly, carbon dioxide builds up in the bloodstream.
Oh. Right.
And carbon dioxide is a potent vasodilator, meaning it causes the blood vessels to widen.
So the vessels in your head are expanding.
Exactly. Those blood vessels in the brain are expanding, pushing against the skull, creating a throbbing headache right out of the gate.
Wow. And what about that hour of just intense grogginess?
That is known clinically as severe sleep inertia. Your brain is so desperately starved for the deep sleep it was denied all night that it actively resists transitioning to a waking state.
It's like your brain is saying, no, we didn't finish the job, put me back under.
Literally. The biochemical signals promoting sleep are still heavily present in the brain because the biological checklist of nighttime repair was never completed.
Spending an hour every morning just trying to feel basically functional is a massive drain on a person's quality of life.
It's a huge quality of life issue.
But the daily fatigue is almost a distraction from the real danger here, isn't it?
It really is. It's just the tip of the iceberg.
Right. Because if the throat collapsing is the mechanical failure and the dropping oxygen is the chemical trigger, we really need to look at what happens to the internal organs when they are subjected to this nightly war zone.
And if we connect this to the bigger picture, this is where the medical perception has radically shifted.
We have to stop looking at this as a sleep disorder.
Right. Yes. We have to start looking at it as a primary risk factor for chronic systemic disease.
So what are the heavy-hitting complications mentioned in the source?
The clinical data we are reviewing links severe, untreated obstructive sleep apnea directly to hypertension, cardiovascular disease, type 2 diabetes, stroke, and even clinical depression.
Stroke and depression.
Yes. We have moved entirely out of the realm of feeling tired and into the realm of life-threatening pathology.
Yeah, the correlation with atrial fibrillation and heart attacks is particularly terrifying. We are literally talking about the potential for premature death.
And there's hard evidence for this. Pioneering studies published in the Journal of Clinical Sleep Medicine and The Lancet show these direct correlations between untreated severe apnea and myocardial infarction heart attacks.
So what does this all mean for the body? To understand how a collapsed airway leads to a heart attack, let's break down the trio of systemic breakdowns outlined in the research.
Okay, let's do it.
We've got cardiovascular stress, systemic inflammation, and metabolic dysregulation.
Those are the big three.
Let's start with the cardiovascular system. We already established that every time the throat closes, the brain dumps adrenaline into the blood to force an arousal.
Right.
And adrenaline causes blood vessels to constrict and the heart rate to spike.
Yes. And if we look closely at the mechanical forces at play during an apnea event, it is incredibly damaging to the heart.
How so? Mechanically, I mean.
Well, you mentioned the paper straw analogy earlier and the negative pressure in the chest.
Right, the vacuum.
When the diaphragm pulls down against a blocked airway, it creates a massive vacuum inside the thoracic cavity. And guess what sits right in the middle of that cavity?
The heart.
The heart. That extreme negative pressure physically pulls on the walls of the heart, particularly the thinner walls of the atria.
Oh my God, that is a mechanical nightmare.
It really is.
So the heart muscle is physically stretching and distorting because of the vacuum in the chest.
While simultaneously, the adrenaline is forcing it to beat faster.
And the blood vessels are constricting, meaning the heart has to pump much harder to push blood through the body.
Furthermore, it is doing all of this while the oxygen supply in the blood is plummeting.
So the heart is working harder than ever while choking.
The heart muscle itself is being starved of oxygen at the exact moment its workload is being multiplied.
Wow. Think about the engine of a car.
Okay.
Normally, when you park it in the garage at night, you turn it off. The engine block cools down, the oil settles, the whole system just rests.
Right, baseline.
Untreated sleep apnea is like putting the car in neutral and slamming your foot on the gas pedal, redlining the RPMs over and over again for 8 straight hours.
That's a great visual.
And while you are redlining the engine, you are also choking off the air intake. If you do that every single night for years, the engine block is going to crack under the unnatural pressure.
Absolutely. Your cardiovascular system simply isn't designed to withstand that kind of chronic nightly abuse.
So what actually breaks first?
Well, this combination of physical stretching, extreme spikes in blood pressure, sympathetic nervous system overdrive, and hypoxia causes profound shear stress on the endothelial cells.
The inner lining of the blood vessels.
Right, the inner lining of the vessels and the heart. Over time, this physical stretching of the atria alters its electrical pathways.
Oh, which causes the arrhythmias.
Exactly. That is the direct mechanism for developing issues like atrial fibrillation.
And when that endothelial lining begins to sustain those micro tears from the shear stress, the body attempts to heal it, right?
Yes, which leads us directly into the second pillar of systemic breakdown, systemic inflammation.
Because the body's trying to fix the damage.
Right. When tissues are subjected to repeated intermittent hypoxia, they release specific proteins called hypoxia-inducible factors.
So they're like molecular distress flares.
Exactly. They act as distress signals, triggering a massive immune response. The body floods the bloodstream with inflammatory markers like C-reactive protein and various cytokines.
The immune system basically thinks the body is under attack or sustaining massive trauma because of those cellular distress signals.
Yep.
So it triggers inflammation to heal the damage. But because the damage happens every single night, the inflammation never turns off.
It becomes chronic.
And chronic, low-grade systemic inflammation is the bedrock of modern disease.
It really is. When blood vessels are constantly inflamed, plaque accumulates much faster.
Leading to atherosclerosis.
Right, the hardening and narrowing of the arteries. This is the pathway to stroke and heart attacks.
And those inflammatory cytokines also interfere with insulin signaling at the cellular level, right?
Yes, which brings us to the third systemic breakdown, metabolic dysregulation.
The cascade just keeps accelerating
It's a vicious cycle.
because the body is surging with stress hormones, cortisol and adrenaline, which naturally prompt the liver to release stored glucose into the blood.
Because the brain thinks you need energy to fight or flee a threat.
But you are literally just lying in bed.
Exactly, so your blood sugar spikes.
But your cells, heavily bathed in those inflammatory markers you just mentioned, become resistant to the insulin, trying to push that sugar into the cells.
The cellular receptors for insulin literally become blunted by the systemic inflammation and the constant presence of cortisol.
So the sugar just stays in the blood.
Right. The pancreas has to pump out more and more insulin to try and overcome this resistance. Eventually, the pancreatic beta cells become exhausted, blood glucose levels remain chronically elevated.
And you cross the clinical threshold into type 2 diabetes.
It is a direct, measurable domino effect.
Let me make sure I have this straight. Airway collapse leads to hypoxia, leading to sympathetic arousal, leading to vascular damage, leading to inflammation, culminating in profound metabolic failure.
That is exactly the pathway.
It is a perfect storm of biological degradation. And honestly, the most dangerous aspect of this entire cascade is that the patient is unconscious while it's happening.
That's the scariest part.
The systemic damage quietly accumulates in the dark. I mean, a person might go 5, 10, or 15 years feeling perpetually exhausted, maybe thinking they are just getting older or working too hard,
Blaming it on stress.
completely unaware that their vascular system is being shredded night after night.
Which presents a massive diagnostic challenge.
Right. Because if the patient has no conscious awareness of the micro-awakenings and subjective reporting is practically useless, how do we shine a light into that dark room?
Well, historically, diagnosing this required a polysomnography.
A sleep study.
Yeah, a sleep study conducted in a clinical lab. A patient would have to go to a specialized facility, get wired up with dozens of electrodes measuring brain waves, eye movement, heart rate, respiratory effort.
Sounds super relaxing.
Oh, incredibly. And then they'd have to try to sleep in a strange bed while technicians monitored the data.
It sounds expensive and highly inconvenient.
It was. And inherently flawed because people rarely sleep naturally in a clinical laboratory environment.
Which is why the technological leap we are seeing now is so critical. We are taking the diagnostics out of the sterile lab and moving it into the patient's actual bedroom.
Yeah.
We're utilizing artificial intelligence and machine learning to analyze the data. We are no longer relying on a human technician to manually count how many times someone stops breathing.
No, we are unleashing advanced algorithms on the problem.
And what's fascinating here is how powerful that AI is.
The application of machine learning to sleep diagnostics is arguably one of the most significant advancements in the field.
Because of the wearables.
Exactly. When we use high-resolution, at-home diagnostic wearables today, the sensors are collecting an ocean of physiological data.
Like what kind of data?
They are tracking microfluctuations in blood oxygen saturation, peripheral arterial tone, heart rate variability, and actigraphy, which measures movement.
And a human clinician reviewing a standard readout is primarily looking for the macroscopic events, right?
Right, the obvious prolonged cessation of breathing.
But AI isn't just looking for the obvious pauses. It is looking for the microscopic fingerprints of the disease.
It's looking at the interplay between multiple data streams simultaneously.
That's incredible.
Exactly. The neural networks are trained on millions of hours of sleep data. They can detect the subtle interconnected patterns that precede an event.
Wait, really? Before it even happens?
Yes. For example, the AI can recognize a highly specific, minute change in the heart rate variability that occurs precisely 3 seconds before the airway begins to narrow.
Oh, wow.
And it correlates that with a micro drop in blood oxygen that a human eye would completely dismiss as signal noise.
So it synthesizes these thousands of data points to map out the individual's exact sleep architecture.
Yes, sleep architecture.
I love that phrase. Sleep architecture is such a great visual concept. It's like the structural blueprint of how your brain moves through the cycles of sleep.
It is. And the AI algorithms reconstruct that entire blueprint.
So they can identify exactly where the structure is fracturing.
Exactly. They can see the sympathetic nervous system spiking in the lighter stages of sleep, proving that the body is fighting to keep the airway open even before a full collapse happens.
So it's catching it super early.
Yes, it identifies a state of chronic upper airway resistance that might not even fully register as an apnea event yet, but is still causing systemic stress.
And that predictive capability fundamentally alters the medical approach.
It shifts the paradigm from reactive crisis management to true preventative care.
Because the AI is so sensitive, we can identify these subtle physiological abnormalities long before the patient develops the downstream consequences.
Right. We don't have to wait for the endothelial lining to tear or the insulin resistance to set in.
We catch the kink in the hose before the engine block cracks.
Exactly.
For anyone listening, that is the ultimate takeaway regarding modern diagnostics. If you have chronic fatigue, high blood pressure that resists medication, or morning headaches, the barrier to finding out what is happening in the dark has never been lower.
It's so accessible now.
At home, AI-driven diagnostics provide clinical-grade insights from the comfort of your own mattress.
But identifying the mechanical failure is only the first step.
Right, because if the AI confirms that the pharyngeal anatomy is collapsing, the immediate engineering challenge is figuring out how to physically prop that airway open.
We have to override the anatomical failure.
And the treatment modalities have evolved in parallel with the diagnostics, right?
They have. The foundation of treatment, the gold standard for decades, relies on pneumatic physics.
Continuous positive airway pressure.
CPAP.
Yes, CPAP. The CPAP machine. It is easily the most recognized treatment, but I feel like it is often misunderstood.
Highly misunderstood.
It consists of a bedside unit, a hose, and a mask that fits over the nose or both the nose and mouth.
Cool.
But the mechanism of action is brilliant in its simplicity.
It really is.
Because it isn't an oxygen concentrator, and it isn't a ventilator breathing for the patient.
No, not at all.
The machine simply takes ambient room air, pressurizes it, and pushes it through the hose. I think the best way to visualize it is as an invisible splint made entirely of air.
I like that. An air splint?
Like, if you fracture a bone in your arm, an orthopedic surgeon applies a rigid fiberglass splint to hold the structure in place so it doesn't collapse under gravity or movement.
Right. Structural support.
The CPAP operates on the exact same structural principle, but applied to a dynamic internal cavity.
Yes, because you cannot insert a rigid splint into the throat.
Right. It needs to remain flexible for swallowing and movement.
Exactly. By introducing continuous positive pressure into the upper airway, the machine essentially inflates the pharynx from the inside out.
Pushing the walls apart.
The pneumatic pressure is precisely calibrated to be slightly stronger than the negative vacuum pressure created by the lungs during inhalation.
So it physically prevents the soft palate and the base of the tongue from falling backward.
It holds the paper straw open.
But as effective as that pneumatic splint is, human sleep isn't static, is it?
No, it's very dynamic.
The original CPAP machines just blew air at one continuous pressure setting all night long.
Which was a big problem.
If your pressure was set at a level 10, it blew a level 10 whether you were falling asleep, deeply asleep, on your back or on your side.
Yes. And that constant unyielding pressure is a major reason why, historically, a lot of patients rip the mask off in the middle of the night.
It felt invasive.
Patient compliance was a massive hurdle.
This is where the technological advancements in positive airway pressure therapy have been revolutionary.
Absolutely.
We move from continuous pressure to auto-adjusting algorithms, known as APAP or auto-titrating CPAP.
Right, and these modern devices are essentially smart computers.
They don't just push air, they measure the back pressure.
Yes, they constantly monitor the airflow resistance in the mask on a breath-by-breath basis.
So the machine is actively listening to your airway.
Precisely.
How does that work in practice?
Well, if you are sleeping on your side during light sleep, your airway might be relatively stable, so the machine drops the pressure to a very low, comfortable level.
Okay.
But when you roll onto your back, gravity immediately pulls the tongue backward, increasing the resistance.
Right. Choking the airway.
The device senses that narrowing of the airway through the pressure feedback loop and smoothly increases the air pressure.
Before it even closes.
Yes, to stabilize the tissue before a full collapse occurs. And once you roll back to your side, it lowers the pressure again. It provides dynamic, real-time structural support tailored to the exact physiological need of that specific minute of sleep.
That real-time adjustment completely changes the user experience.
It's a game changer for compliance.
But even with smart algorithms and infinitely better mask designs, some people simply cannot tolerate sleeping with something attached to their face.
It's true. The sensory input is too much, or they suffer from claustrophobia.
Which brings us to some of the most remarkable, futuristic interventions we are seeing in the medical field right now.
Here's where it gets really interesting.
We are moving beyond external pneumatic splints and entering the realm of implantable biotechnology.
Yes. The development of hypoglossal nerve stimulation is a paradigm shift for patients who are intolerant to CPAP.
Nerve stimulation.
Yes, it is an active physiological intervention rather than a passive mechanical one.
Okay, explain how this works.
It utilizes a device that is surgically implanted under the skin in the upper chest, very similar in size and placement to a cardiac pacemaker.
But instead of blowing air to hold the throat open, it actively controls the muscles of the throat. The mechanics of this are incredible.
It relies on precise neurological communication. The implanted device has two main leads.
Okay.
The first is a sensing lead that sits between the ribs and monitors the expansion and contraction of the chest wall.
So it's constantly tracking the patient's respiratory rhythm.
Exactly. And the second lead is tunneled up the neck and carefully wrapped around the hypoglossal nerve.
And what does that nerve do?
This specific cranial nerve is responsible for the motor control of the tongue and the main dilator muscles of the upper airway.
Let me get this straight. The sensor in the chest feels the patient starting to take a breath in. It sends a signal to the main computer in the device, which immediately fires a tiny electrical pulse up the wire to the nerve in the neck.
Yes.
And that electrical pulse stimulates the nerve, causing the base of the tongue to push forward and the throat muscles to flex and stiffen, just enough to keep the airway open while the air is pulled in.
You've got it. It is essentially giving the muscles the exact neurological command that the brain is failing to send during deep sleep.
That is just sci-fi little medicine.
It bypasses the muscle atonia of sleep entirely, and it is highly synchronized. It only stimulates the nerve during the inspiratory phase of the breath, relaxing during exhalation.
And the patient just controls it.
Yeah, the patient has a remote control to turn the device on when they go to sleep and off when they wake up.
And does it actually work well?
The clinical efficacy for this type of neurostimulation has been outstanding. It often drastically reduces the apnea-hypopnea index and alleviates the systemic hypoxic load without requiring any external equipment on the face.
It is a profound example of bioengineering solving a mechanical biological failure.
It really is.
And for some patients, the primary issue is purely anatomical volume, right? They just have too much physical tissue crowding the space.
In those cases, surgical options attempt to permanently alter the architecture of the airway.
Like getting your tonsils out.
More extensive than that. Procedures like a uvulopalatopharyngoplasty, where surgeons remove the tonsils, the uvula, and trim the soft palate to create a wider physical diameter.
Oh, wow.
Or even more complex orthognathic surgeries that physically move the upper and lower jaws forward to permanently expand the entire pharyngeal space.
Those sound pretty intense.
Those surgical interventions are significant and typically reserved for patients where anatomical crowding is identified as the undeniable primary culprit.
Okay, but what about options that aren't surgery, but also aren't a CPAP?
The spectrum of treatment also includes highly effective, non-invasive mechanical alternatives.
No.
For mild to moderate obstructive sleep apnea, oral appliance therapy is incredibly successful.
These are the mandibular advancement devices.
Yeah.
They look like the clear plastic retainers or mouth guards athletes wear. But their function is entirely structural. They are custom calibrated by dental sleep medicine specialists.
And the mechanism of action focuses on the temporomandibular joint.
The jaw joint.
Right. The lower jaw, the mandible, is essentially a hinge. A vast amount of the soft tissue that collapses during sleep, specifically the base of the tongue, is anchored to that lower jaw.
Okay, I see where this is going.
When you lie on your back, gravity pulls the jaw downward and backward, taking the tongue with it into the airway.
So a mandibular advancement device hooks over the upper and lower teeth and acts as a mechanical stop.
Exactly. It physically locks the lower jaw in a slightly forward, protruded position.
By pulling the anchor point forward, you pull all the attached tissue forward with it, stretching it tight.
Right. It physically prevents the tissue from falling backward into the void of the throat.
It is a brilliant, silent, non-invasive mechanical fix.
Very elegant.
So between the AP machines, the nerve-stimulating implants, the surgical reconstruction, and the oral appliances, modern medicine has built an incredibly robust arsenal to physically keep the airway open.
But, and this is a big, but relying solely on medical devices or surgery ignores a massive component of the pathology.
The lifestyle factor.
Yes, the physical therapies manage the mechanical failure at the site of the collapse, but the patient's overall physiological environment drastically influences the severity of that collapse.
This is where lifestyle optimization transitions from general health advice to a targeted medical intervention.
Precisely.
Because you cannot talk about sleep apnea without addressing the physics of body composition.
No, you can't.
The tissue surrounding the neck is not exempt from weight gain. Adipose tissue, or fat, accumulates in the cervical region just as it does in the abdomen.
And that external weight puts direct physical pressure on the soft tube of the pharynx.
Right. The heavier the tissue outside the throat, the more internal pressure is required to keep it open, and the easier it collapses under the negative pressure of a breath.
The correlation between BMI and obstructive sleep apnea is undeniable.
But the lifestyle interventions go much deeper than simply mechanical weight reduction.
Yes, we have to look at the biochemical environment of the tissue itself, specifically the role of systemic inflammation, which we touched on earlier.
Because what you eat affects your throat.
Absolutely. A diet high in hyperprocessed foods, refined carbohydrates, and industrial seed oils acts as a continuous trigger for pro-inflammatory cytokines.
And when you maintain a diet that constantly triggers inflammation, your body retains water and your tissues literally swell, edema.
Exactly.
And that swelling isn't just in your joints. It happens in the mucosal lining of your airway.
Precisely. If the walls of the airway are inflamed and swollen, the internal diameter of the tube is significantly reduced before you even lie down.
Oh.
By adopting a strict anti-inflammatory diet, prioritizing whole foods, omega-3 fatty acids, and dense micronutrients, you actively reduce the cellular edema in the pharyngeal tissues.
So you are physically widening the diameter of the airway from the inside out just by resolving the localized inflammation.
Exactly right.
Which provides the missing context for why exercise is heavily prescribed for sleep apnea patients.
Yes.
It's easy to understand how losing weight removes the physical pressure around the neck. But even independent of weight loss, regular cardiovascular and resistance training has a profound impact.
It does.
The source specifically notes that yes, exercise can help sleep apnea, but how does lifting weights or running sprints structurally protect a collapsing throat?
It alters the metabolic landscape. Skeletal muscle is highly metabolically active tissue.
Okay.
When you engage in consistent exercise, you radically improve insulin sensitivity, meaning your body requires less insulin to manage glucose.
And we know insulin resistance is tied to inflammation.
Right. This reduction in circulating insulin directly correlates with a reduction in systemic inflammation. Furthermore, exercise promotes the release of anti-inflammatory myokines from the muscle tissue itself.
So the muscles you build during a workout act like a pharmacy, releasing compounds that combat the inflammation swelling your airway.
That's a beautiful way to put it. And on top of that, you are improving the cardiovascular tone and the mitochondrial efficiency of your cells.
Why does mitochondrial efficiency matter here?
Because if your mitochondria are highly efficient due to physical training, your body's base requirement for oxygen is optimized. If an apnea event does occur, a highly conditioned metabolic system can withstand the transient hypoxic stress slightly better than a metabolically compromised system.
The lifestyle inputs, diet, exercise, and sleep hygiene create a physiological environment that actively resists the pathology of the disease.
Exactly.
It is empowering because it gives the patient agency. You aren't just relying on a machine blowing air, you are remodeling your cellular environment.
You're taking control.
And that idea of treating the unique biological environment of the individual brings us to the absolute frontier of sleep medicine.
This is where it gets really exciting.
Because Everything we have discussed so far, from CPAP to implants to diet, is essentially reactive. We find the problem, and we apply a generalized solution to fix it.
Right.
But the future of this field, which is developing rapidly, is rooted in the genetic code.
The pivot toward precision, genetically informed medicine, is the most exciting evolution in the field.
Tell me more about that.
Well, for decades, we have viewed obstructive sleep apnea largely as a disease of obesity and aging.
But that's not always the case.
No. Clinical observation constantly contradicts that narrow view. We routinely see young, highly athletic individuals with single-digit body fat suffering from severe anatomical airway collapse.
So what's causing it for them?
The missing variable in those cases is the genetic blueprint.
Researchers are now looking at the massive data sets to isolate the specific genetic markers that dictate susceptibility.
And it is a highly complex multigenic trait. There isn't just a single sleep apnea gene.
Right. They are looking at the genetic markers that dictate craniofacial architecture.
Exactly. The physical shape of the skull, the width of the maxilla and mandible, the position of the hyoid bone in the neck.
These are highly heritable, genetically determined traits.
Yes. If you inherit the genetic blueprint for a narrow palatal arch and a recessed lower jaw, your pharyngeal airway is naturally going to be compromised, regardless of your body weight or lifestyle.
It's just built smaller.
Right. And identifying these craniofacial genetic markers early in life allows for preventative orthodontic interventions during childhood development.
So potentially expanding the airway before the pathology ever takes root.
Exactly.
But it's not just the shape of the bones, is it?
Oh, not at all.
They're also identifying genetic variations in the neuromuscular control of the respiratory system.
This is the neurological component. There are genes that govern the excitability and the responsiveness of hypoglossal nerve and the genioglossus muscle.
The ones that hold the tongue forward.
Right. If a patient possesses a genetic variant that blunts the neurological drive to those specific dilator muscles during the transition from wakefulness to sleep,
their airway will collapse, even if their craniofacial structure is perfectly normal.
Exactly.
And mapping these specific genetic pathways is what will eventually lead to true, personalized medicine.
This raises an important question, right? How do we use this?
Right. We will move away from the trial and error approach. A doctor won't just look at a sleep study, hand you a CPAP, and hope for the best.
No. The clinical pathway will completely transform.
How so?
Imagine this. A simple cheek swab or blood draw will map the patient's specific genetic predispositions alongside their AI-driven sleep architecture data.
So you have the software and the hardware map.
Exactly. The clinician will be able to look at the profile and definitively say, your apnea is not primarily driven by craniofacial structure, so an oral appliance will be ineffective.
That saves so much time and money.
Right. They could say, your genetic profile shows a highly blunted neuromuscular drive during REM sleep, but you also possess a genetic marker indicating you are highly responsive to hypoglossal nerve stimulation. It eliminates the guesswork completely. It directs the patient immediately to the precise intervention that matches their unique biological failure.
We are moving toward a future where we don't just treat the symptom, we correct the specific structural or neurological misfire coded right in the DNA.
It's an incredibly hopeful vision for the future of healthcare. It represents the pinnacle of proactive medicine, moving us from generalized protocols to deeply individualized curative strategies.
This journey we've taken today completely shatters the old paradigm. I mean, we started by looking at a condition that was laughed off as a snoring issue, an annoyance that supposedly just bothered whoever was trying to sleep next to you.
Right.
But by pulling apart the mechanics, we've exposed a biological crisis affecting 1 billion people.
A staggering number.
We've seen how the simple failure of the soft tissue in the throat, the paper straw collapsing, initiates a devastating hypoxic cascade.
And we map the shock waves of that oxygen deprivation,
revealing how the nightly spikes in adrenaline and blood pressure tear at the endothelial lining, causing the cardiovascular stress, the chronic systemic inflammation, and the metabolic breakdown that leads straight to heart disease and diabetes.
But we also explored the incredible technological renaissance happening in response.
We moved from the clumsy sleep labs of the past to the predictive power of artificial intelligence, capable of mapping the microscopic fractures in our sleep architecture.
We broke down the physics of pneumatic air splints, the bioengineering of nerve-stimulating implants, and the mechanical brilliance of oral appliances.
And we grounded all of that in the profound power of metabolic health, showing how reducing systemic inflammation physically alters the internal landscape of the human airway.
It's a comprehensive view.
And the ultimate goal of this deep dive is empowerment. Whether this intricate physiological battle is happening in your own body or in the body of someone you love, understanding the mechanics is the absolute prerequisite for change. Knowledge here isn't just an abstract concept. It is a literal pathway to reclaiming your baseline health. You cannot possibly hope to achieve your mental or physical potential if your internal systems are spending 8 hours a night fighting a desperate war just to secure enough oxygen to survive until morning.
The scale of that hidden war is really what I want to leave you to consider today.
Yeah, let's talk about that.
We noted that 1 billion people, 1/8 of humanity, are estimated to be engaged in this nightly struggle.
It's hard to even fathom.
Think about the symptoms we analyzed. Waking up in a suffocated state, the throbbing hypercapnic headaches, the profound, unyielding sleep inertia that demands an hour just to reach a functional baseline.
Just to start the day.
Now, apply that clinical reality to the broader world around us.
Okay.
We constantly analyze the epidemics of global anxiety, the pervasive, deep-seated societal exhaustion, the collective burnout, and the feeling that everyone is constantly running on empty.
Everyone feels it.
But when you look at society through the lens of mass, untreated hypoxia, the picture changes entirely.
That is a fascinating point.
It fundamentally forces a reevaluation of our modern condition. How much of that societal burnout, how much of that fractured attention and chronic exhaustion is actually the psychological burden of modern life?
Right.
And how much of it is the direct biological consequence of an invisible, highly treatable global physiological crisis?
Wow.
How much of the world's collective anxiety is simply the manifestation of a massive 1 billion person oxygen deficit hangover?
It is a staggering perspective that completely rewrites how we understand human energy and public health.
It really is.
We assume the bedroom is a safe harbor, but we must ensure it actually is. You now have the knowledge to look at the mechanics of your own rest, to utilize the diagnostics, and to reclaim the restorative power of sleep.
Well said.
Thank you for joining us on this deep dive. Keep questioning the mechanics of your own physiology, keep exploring the incredible complexity of the human machine, and never take a good night's sleep for granted.